Well, good afternoon, everybody. I hope you are settling in and have arrived just in time. My name is, just for those of you who have not met me already, but my name is Carmel Clancy. I am going to be the incoming president for IntNSA, and I am also the conference chair. And I am absolutely delighted that I will be moderating and facilitating for this afternoon's live webinar. And I'm extremely pleased. I can't tell you how excited I am to meet for the first time Dr. Marica Ferri, who is an epidemiologist with the European Monitoring Centre for Drugs and Drug Addiction, the EMCDDA. I'm sure that those of you who are certainly within the European region will know this organization extremely well. It is an amazing group, an institution, and pulls together an overview of the drug situation within the European boundary. And we are absolutely thrilled to be able to welcome Dr. Ferri to our Congress to speak with us this afternoon. It is, of course, 5 p.m. in Lisbon. So we are well into our day, although we know that probably for our American colleagues and friends, you're just waking up. So I hope you have a good, strong coffee. So welcome to the session. Before Dr. Ferri speaks, I'd just like say a little short few words about her background. So as I mentioned, Dr. Ferri is an epidemiologist with an interest in evidence-based medicine and public health, after having coordinated the Cochrane Drugs and Alcohol Group, she moved to work in the field of guidelines development and implementation in the area of stroke, first interventions and management, low back pain, tonsillectomy, appropriateness, and thromboembolisms. In 2009, she joined the European Monitoring Centre for Drugs and Drugs Addiction, and she leads the support to practice sector. As such, she promotes professional training, dissemination of evidence-based practice examples, and implementation of quality assurance for intervention systems and services. She is responsible for the scientific program of the EMCDDA, and I'm sure you will, having heard those qualifications, agree with me, we couldn't have anybody better talking to us this afternoon or this morning. So welcome, Dr. Ferri. We are absolutely thrilled that you're here with us. Please do settle in, because this is an unusual way to present. We're really super aware that it's difficult looking down a screen to think about engaging with people, but hopefully we'll have lots of people joining. And for those who are joining us, just to let you know, Dr. Ferri will possibly, pose some questions, so stay alert, because we would like you to maybe put some answers to those in the Q&A section. And if you have particular questions you'd like to put to Dr. Ferri at the end of her presentation, you should be able to just post those in, and we will be moderating that. You will see on screen at the moment, we've got Dr. Fanili and Dr. Berda who've joined us as well. Maybe you both would like to just also say a quick hello. Kathy?
Hello, everybody. I just want to say good morning, good afternoon, and like Dr. Clancy, I am so excited to hear Dr. Ferri. My background is in epidemiology as well, so and I've been a public health nurse for 37 years, so I really enjoy this presentation she's about to deliver. And I will be your president for just a couple more weeks, and then Dr. Clancy will take over. So looking forward to it. Thank you, Dr. Ferri.
Thank you,
Dr. Thank you all for coming too.
Yeah, thank you. And Dr. Berda, welcome.
Yep. Good to meet you, and I can't wait to hear what you have to say, Dr. Ferri. I'm an individual psychiatric nurse practitioner, so evidence-based all the way, and would really like to hear the ideas coming from Europe, and maybe talking a little bit about what I do in my practice as well. I'm also faculty at a major university here in the States. So welcome.
Thank you, Dr. Berda. Wonderful. So hopefully that settled you in a little bit, Dr. Ferri. I believe you're going to run your own slides. So when you're ready, if you do a share, we're going to go behind the scenes now and leave you to talk to us down the camera, and then we'll come back on again once you're finished. All right. All the best. Thank you so much.
Thank you very much. Thank you for having me. I'm quite amazed by the importance of this conference, by the length and the depth of this conference. I hope I will be able to share some ideas with you. As I said in my abstract, I expect to learn more than what I will be saying. I will talk a little bit about I cannot go ahead already. Let me see. Okay. So about, I would like to talk with you a little bit about my organization, the European Monitoring Center for Drugs and Drug Addiction, as already has been mentioned. And then I'd like to discuss with you a little bit about the role of nurses in drugs-related problems, and a role that is enormous and impossible to define, and then asking to you some questions like, what are the main issues? We can count on quite a sound and solid evidence for interventions, but still there is a gray area of issues that are not yet appropriately answered by research, and for which we need to share knowledge to understand what is the right thing to do. I will also talk a little bit about the observation we made during the recent COVID-19 related emergency, and how your profession has adapted to the new conditions, trying to take care of the most vulnerable target groups. And then I will present the resources to support practice that at the EMCDDA we have up to now. And we will see what remain some open questions and what are our way forward, including, we hope, some future collaborations with your organization to improve our level of responses and sharing of knowledge. So talking about the EMCDDA, is the European Monitoring Center for Drugs and Drug Addiction, was founded at the beginning of the 90s in Europe to respond to a severe opioid epidemics. Since then, during the last 25 years, has been monitoring data, but not only, has also been disseminating evidence and sharing best practices. I joined the center in 2009, exactly with the mandate of developing this area of best practice and sharing of experiences, including training. So it's really my pleasure to be here with you. The EMCDDA has an organization including two main scientific units. One dealing more with health, is where my sector is based, and the other more with security. Altogether, our mission statement is to improve and to provide Europe with a health and secure environment. To do that, we have a network of partners in all the European countries, plus Norway and Turkey. And we have focal points that are sending us data, are disseminating our contents, and we are a network of excellencies working together. The mission of the unit where I work is saving lives and contributing to a healthier Europe. So there is a huge commitment to be effective and to be close to the most vulnerable groups of people in our target population. And then I'd like to try define with you what is the role of nurses. I was chatting before with Dr. Clancy, and I was mentioned to her that the nurse profession is defined by differentiation with other profession. I was saying it's a little bit like the mother. She's doing everything that has to do with their kids and more, and there are unlimited expectations of what she can do with the kids. So nurses are active, fundamentally active in prevention, in treatment, harm reduction, and social integrations. For example, when we think of prevention of drugs-related problems, the first thought is nurses working in the school, but also those working in the community health promotion, where probably drugs are not the first content, but still the promotion of a healthier lifestyle includes reduction of dangerous behavior, including use of drugs. And then the screening, the first observation of some potential problems in kids, but not only, also at family level. When we look into treatment, I was mentioning before with Dr. Clancy this extraction by a booklet that she also has written. Those who have the most clinical experience, such as consultant nurses, will be able to operate at a senior level with a degree of overlap with the role of competencies of specialist addiction doctors. So it's such a big expectations around what this professional role can do, that there is also overlap with specialists. And it's nice that this is the type of definition. Another article by Momba and colleagues says, we believe that the key areas in which nursing as a profession could be influential include advocacy, patients education, nursing education, screening, brief interventions and referral to treatment, like SBIRT, increasing competency, and shaping of health policy through research and evidence-based practices. So it's everything to some extent. But nurses are also very active in harm reduction. So, for example, this is an article by Limbu and colleague talking about the role of nurses in harm reduction in Eastern countries where harm reduction is less accepted. And it says, nurses act as an information bridges between communities of people who use injection drugs, law enforcement, political and healthcare stakeholders. So once again, is a role that includes also political expertise, diplomacy. So it is very difficult to describe. When we look into social integration, once again, nurses work for the social reintegration of people who use drugs in collaboration with social workers and multidisciplinary teams. Imagine that they work with people post-release from prison, or people that comes out of a therapeutic community, or people that end a detoxification program, or so many different situations where the role of nurse is present and very important. And then we have some special settings, for example, in prisons, orphanages, migration camps, therapeutic communities, homeless shelters, military environment. And I can go on, like, for example, in the workplace, those that are able to identify if someone shows signs of problems. So it's an amazing, enormous group of different professions into one profession. When we look into the vulnerable groups that are helped by nurses, we see sex workers, women victims of violence, people with trauma, people with mental health problems, LGBT people especially in stigmatizing environment, single parents, elderly, kids with special needs. So if you can see, I included the symbol of the infinite. And then other tasks, for example, we were talking before, supervised injection facilities. Nurses are typically working in this environment, sometimes with a difficult and delicate role of welcoming individuals without being able to ask too many questions, try to challenge their own limits. Just to give to you an example, I recently visited one of these injection facilities in Luxembourg, and I asked to one of the healthcarers what was the most challenging situation, and they expected something like, I don't know, violence and they say there was a pregnant woman coming in, and I couldn't ask what she was using. And I had to repeat to myself that this was a safer environment than anywhere else, but still was very, very challenging to see this woman using drugs. What do they do in supervised injection facilities? They provide safe, compassionate, competent, and ethical care, promoting health and well-being, promoting and respecting informed decision-making, preserving dignity, very important, maintaining privacy and confidentiality, promoting justice, and being accountable. This is really the work description of a superhero. And then other tasks like supervision of prescribed opioid substitution treatment, observation of signs of intoxication. I was giving this other example. When those services that don't want to implement urine screening for fear of discouraging clients from coming, sometimes ask nurses to see if there are some signs of intoxication in order to avoid overdosing. And then in some cases, testing. In some cases is delivering urine testing and observation. And then there is another relatively new area where it's interesting to know how this profession will develop or is developing, that is telehealth. We noticed, especially during the COVID emergency, that in order to reduce the number of people in the services, some of the communication passed to some type of online way. Can be the use of mobile phones, can be the use of email, can be the use of teleconferencing, as this is the case here. So we need to see how do you pose some limitations, because imagine we had some focus group with professionals. I'm from Italy, as you can hear. And you know that Italy has been severely hit by the infection, especially in the first period. So we had some focus group with frontliners, and some of them reported to us that especially at the beginning, there was a lot of anxiety among people. Needed to talk to someone, to ask to be reassured. So the question was how to pose a limit to not being on service 24 hours, 7 days, 7 days over 7. So the questions I would like to launch to the audience is, what are the issues around these undefined, over-present profession? What are the issues that you feel evidence has not supported sufficiently? Where are the gray areas we still need to study together? We still need to call the attention, to bridge the gaps, or sometimes to find responses that are not supported by strong evidence but still are needed. I don't know if there is anybody that wants to write on our questions and answer. Yes, I see that someone is inviting people.
Aha. So the overregulation of methadone programs.
Okay, that's very
Dr.
interesting.
Ferri, is certainly one that's coming through. And if I may, while I have the mic open, I think was flagging with you. I think we don't, you know, you made, I thought, a very good point about this hero complex, you know, because we do so many things, but actually we don't have a good understanding completely across Europe, certainly, and maybe also, I believe, in the US, but I'll let my US colleagues speak to that. But I know that we also have Nigeria, I think, listening in on today's webinar, and many other countries. So about the standardization of what is actually the role of the addiction nurse, and how many addiction nurses do we have? Who are they? Where are they working? We don't have this information. And so therefore that makes it very difficult when we're thinking about you know, looking at the whole of what the profession needs and the evidence base for supporting it, and also the training within this professional group. So these are very serious issues, and they were raised by Dr. Loth yesterday in her webinar about addiction nursing in Europe. So I wonder if colleagues in the United States, and maybe Karan and Kathy, you have a mic, you might want to say something from the US position.
Well, I think that in the United States, we have a routine role delineation study for nurses to try to clarify the differences in the role between the certified addictions registered nurse and the certified addictions registered nurse advanced practice. And I think a similar study would be interesting from a global perspective, especially since we're going to be working to try to advance a nursing certification in addictions nursing, an international certification process.
I agree. The first, I don't know if it is a question or a comment over the overregulation of methadone programs, is one of the points we noticed during the COVID-19 emergency, is that several frontliners mentioned that there were kind of adaptation or facilitation of methadone programs that were not possible before the emergency. And exactly, and there was an amazing definition that our director, Alexis Goosdale, is always repeating. One of the professionals said there was a kind of a gentleman agreement with the drug users. That is very nice, very rare to feel this definition, because the emergency gave a bigger margin of maneuver to make an agreement of mutual respect. So now the question is how much of this, because this emergency showed that some margins are more flexible than we thought before. So we need to see how much of this new working style can be maintained after, if there will ever be an after this emergency. About the description of profession, I mentioned before, during a conference that was held in 2011 by the European Commission on the quality standards to launch the results of an European project on quality standards in drug demand reduction. One of the points that was discussed by the participants from all over Europe was exactly, and there was also one representative from the United States, was exactly the difficulties of comparing the workforces. So I definitely agree with you, that would be a very good joint research program to try to define the geography of the different workforce across Europe, definitely, and also to share experiences and to share professional behavior. So I thank you for these points that I will bring with me.
Dr. Ferri,
yeah.
Dr. Clancy is also involved in a study that some of us in the States and others in Europe have agreed to work with her on. One of these days when we can find time for it, is to understand what nursing faculty understand about addictions, because we want to try to have addictions content integrated into each area of nursing: medical, surgical, psychiatric, public health, and addictions specific. And if the nursing faculty were not taught in their entry-level programs, then they might not be able to teach evidence-based addictions nursing content. So that's a second study that we're very interested in. Dr. Berta and I teach at the same school and want to do that as well.
Definitely, and there are networks of universities with the specific teaching on addiction that is not so common in Europe. Not all the universities have specific courses for addiction medicine. Sometimes it's just in the realm of medicine. So we can create interesting links after this meeting.
Right.
Yeah, that's one of the difficulties, because even the nurses who have some addiction experiences are going on old information. So as we get more and more evidence-based data and things are changing, even in the language that we use, the approach that we take, the time that it takes, the global involvement that's required in order to really get to health, they're in old concepts. So the more we get the education, I think, but also the modeling and getting the research to the actual clinical site is a real block, and one that we come up against on a daily basis. So that's why your talk is so important at this time.
Thank you.
And also we've, thank you for that, Dr. Berta, and a couple of other people engaging in the webinar in the question and answer section are mentioning, which you might want to consider as well, Marica, is state nursing boards, federal SAMHSA, CSAT, recognizing CARNs. Now in the US, there is the Certified Addiction Registered Nurse certification, which is recognized and understood, you know, to offer a certain specialism. And then there's the advanced part of that certification as well. And it's about it's really about Medicare and insurance, Medicaid, you know, recognizing that nurses are offering this sort of level of advanced certification and practice. So, and there's a question about what is that like in Europe. So I think, and that's been followed up actually by another participant who's saying, what are the differences in healthcare across the countries in Europe? Private insurance versus government programs. Is the care different from country to country? And it's certainly, I know that straight away, because in the UK we have the NHS, so it's free at the point of access, for especially for drug use, but that's not always the case across Europe, as you know, Dr. Ferri. So maybe that's also another interesting intersection about the role of nurses in the different provider models between private healthcare, public healthcare, recognition of certification. So quite a complex, quite a complex story.
I'm very happy because I get back with a lot of ideas for further investigations. But the question on the role of private versus public, or with public in Europe, is very relevant. The countries have different stories, and this has an impact not only on the professions, but also, for example, on the collection of data. Italy, as you know, has copied the UK national health systems. So, for example, the country is served by a network of services for drug users. that is relatively easy to put together and to collect data. Many years ago, I did a mortality study where there were more than 500 services. There are other European countries where the insurance cover different aspects, so you don't have this unite picture. This is also why it is so important the work that the MCDA does to give a global picture of what we have, but it's also a big challenge. And definitely we need to know more in order to be able to share our experiences, but also the feasibility of interventions, because we need to know how these are already running. What we cannot introduce changes. We cannot promote different level, advanced level of quality if you do not know already what is there. So now going ahead with my slides, if there are no more comments, you all know what is evidence-based practice in nursing. So it's a way of providing nursing care that is guided by the integration of the best available scientific knowledge with nursing expertise. This approach requires nurses to critically assess relevant scientific data or research evidence and to implement high quality interventions for their nursing practice. Now, because I have been working with evidence-based medicines for almost 2 decades now, probably more. The part that is more interesting for me, and because you are a very well educated audience, we don't need to focus more on the evidence, on the critical appraisals of evidence. We need to focus more, I would say, on this nursing expertise. How can we not quantify, but how can we share and discuss what does it represent? How can we describe what is the individual sensibility that makes you recognize if someone is doing well or is getting depressed and is not the right day to start, for example, the new opioids substitution treatment dosages. This is for me the most interesting challenge, because especially in the sector I'm leading, we did a lot to disseminate evidence-based interventions, but it's more and more clear that the part where we need now to invest more is the implementation side. But what is the implementation side? Is the capacity and feasibility of making this evidence work for the real people that is here now with these opportunities and limitations of this environment. This is the most challenging part for me, and this is where I would like to really collaborate with you. So if we look, one of the many models, the Johns Hopkins nursing evidence-based practice model, we have well represented the research part, the non-research organizational part, the internal factors, the external factors. But once again, the part that is interesting me is here, clinical expertise and patient's preference, because the patient's preference is something that who better than a nurse can read. So this is really, for me, the next frontier of the challenge I'd like to consider. In terms of sources of evidence, you all know the Cochrane collaboration. There is a Cochrane nursing group or field, how they are called now. And it's interesting because they collaborate with all the classical, the traditional editorial groups in order to make sure that the nursing aspects are there considered and described described appropriately. Interestingly, I noticed that only one systematic review in the long list of those that are reported in their website are on drug-related problem. if I'm not wrong, is even a systematic review that has been withdrawn because it wasn't updated, but I don't want to say because I'm not sure, but was on cocaine dependence, meaning that I think it's an invitation also for you to contact the Cochrane and to make sure they consider more drugs-related problems in the nursing area. This is a family picture a few years ago. You may recognize Michael Farrell, Walter Link, David Oxford, the Robert Eli Foxcroft, sorry, it's work in Oxford, but it's called Foxcroft, Marina Davoli, and others. And this is the Cochrane Drugs and Alcohol Group. And they also produce intensively lots of review on evidence-based interventions for drugs-related problem. Once again, probably more collaboration on nursing issues would be welcomed. Other sources you know very well: evidence-based nursing, world views on evidence-based nursing, reflections on nursing leadership. So there is a lot of publications on the evidence, and I'm still interested in this that I call gray area, but it's not gray at all. It's very, very colorful because it's full of feelings, preferences, attitudes, prejudice, stigma, limits to challenge our own limits and the limits of the clients. And this where the real life of people stays. So how can we make sure, once again, I repeat, we are not abandoning the evidence-based model, but still we are considering this area. I promised I wanted to have a look at what we have learned during the COVID-19 emergency at the MCDDA. So as of March 26, if I'm not wrong, we went all home teleworking. And I have to say myself, I was reading in the newspapers, there were two keywords, main keywords. One said, stay at home, and the other said, be connected. And the first thing I thought is, and if you are homeless and you don't have access to technology, what do you do? So we start discussing, and then our director pushed to have a specific area talking about COVID-19 exactly to address the problems of the more vulnerable groups. So we did, some of my colleagues, I also was involved, did something we call the trend spotter methodology. Is systematic identification of literature, any type of literature, including gray literature, to depict the situation. And then there is the confrontation of these information obtained against the data we have. And then there are meetings and focus group with professionals. There is a manual describing better than I can do this methodology. The strength of this methodology is that it can give, it allows to identify something while this is happening. So several exercises were conducted. And when we talked about the use of substances, just in a very, very succinct summary, you have all this information in our website. It was noticed, we are talking about the first period of the self-confinement. So it was between March and June. So there was overall less use of substances. People were at home. There were no flights, less travels, and less social opportunities. Cocaine in particular was less consumed. And this was also confirmed by the analysis of the wastewaters. There were smaller groups of people consuming cannabis more intensively and less people consuming a little of cannabis. And this was also confirmed by the online searches. There are these analysis of the keywords that people search online. Heroin also was less available and probably substituted by other type of substances. There was an increase in the use of alcohol, and there was an increase in emergency presentation for mental health problems. Looking into what happened with the services for drugs-related problems clients, there was a decline in the availability of treatment services and harm reduction interventions. Some services closed. In others, there were lack of personnel because of infections. And in others, the opening hours were reduced just to avoid overcrowding spaces. So there were needs to reduce presence and also to implement hygiene rules. There was a reduction of patients coming to services and seeking first-time help, around 50%. We conducted a set of focus groups in Italy for the reason that it was strongly affected by the infection. And what they reported is that the situation was very diverse across the country. You know, it's a very long country. In some southern areas, less people appeared in the services, probably because the police stopped people in the street to ask them where they were going. So maybe some of the clients didn't want to declare that they were going to a drug center. In the north, in some cases, more people was coming to the services, asking also for masks, for gloves, for other type of assistance. There was a kind of a spontaneous use of internet and mobile communications. There is a misspelling. What the healthcare reported is that when clients didn't show up, they start calling over the phone. So it was very spontaneous. Sometimes probably also breaking some privacy rules, but just to make sure there was some types of connections. Only after some days, it started to become more organized. And one of the questions is how much this will be maintained. As it was said before, some of the counseling probably could go ahead through internet, although probably there will be some adaptations needed. So in terms of market, this is more difficult for me to report. It's not my area of interest, but I think it's important to mention. There was a joint EMCDDA Europol report mentioning what has happened in the first periods of the emergency. So there was, because of the restrictions on travels, some aspects of the market was disrupted. This was more evident at the distribution level. In some cases, organized crime showed resilience and found ways of trafficking. In cocaine, it looks like an increase in price and decrease of purity in some countries, showing that there was a decrease of availability. And apparently trafficking went on through maritime connections. Cannabis showed a kind of a shortage in the resin products, but possibly a stockpiling in the herbal products. Heroin was also shortage, and synthetic substances production in Europe probably reduced or consume reduced because of the close of social clubs and venues and festivals and so on. So overall, a kind of a reduction in use. Some open questions from this anecdotal evidence talking to frontliners and health carers. There was this type of solidarity, a kind of respect for those nurses and doctors that were there working in spite of the risks of infections, and also respect from the healthcare to clients that were lining up, waiting their time, wearing the mask. So it was a kind of unprecedented solidarity. Will it remain? Will this new model leave some trace when things will be back to normality? Another comment that were made is that apparently there were no reported infection among the clients. So is it because if infected they didn't report? Is because for some reasons they weren't exposed? There were infections among health carers, up to the level of having to close some of the services. The use of telehealth will remain after the emergency, and how making sure that we are not excluding those that are not accessing technology for some reasons. And then how to self-confine homeless. There were some very brave projects going ahead to find places, safe places for people, for homeless people. There are pictures of street worker going around to find homeless and to accompany them to safe shelters. And some towns, some municipalities declared the end of homelessness. Let's see if they will be able and if this experience will remain. Other dramatic experiences with domestic violence, and some cases where self-confined was keeping together the victims with their perpetrators. Are there any comments, any remarks over what I have reported? Anything it's worth bearing in mind, annotating for our future meetings or further discussions? Your experiences with the COVID-19 emergency were different from what I reported. I don't know if anybody wants to say something, not obligatory. Dr. Berda, I see you.
Yeah, I just wanted to say that in an outpatient psychiatric practice that I'm in, I think we have opened more availability. And so I am now seeing my patients more often and for longer periods of time. I'm not on the same kind of schedule I was pre-COVID because of the anxiety and all of the impacting stressors that the patients have. And I also have given everyone my phone number so they can text me. So they can text me outside of our appointment times, and they give me 48 hours to respond because sometimes I'm distracted. And I find that that is working. And I think what COVID is showing us is that, as you were saying earlier, nursing is really a celebration of the feminine parts of healing. It's healing, it's the art of healing, and that requires relationship. And in terms of clinical experience, I think that comes with time. The clinician has to be comfortable going into those quiet areas and really looking at where the person is that we are serving and what it is that they need at that time. But I think the therapeutic relationship and looking at the whole person and all of their situations is really key. And it's not something we can do in the quote unquote business of things. It's really in the art of our practice, and our presence is so important. I think for some of my patients, most of them they have co-occurring disorders. Some are in active treatment for their addictions. Some are just trying to maintain recovery. It's the knowing that there's availability of someone who knows them that keeps them on their strength in giving them what they need to meet their goals. I have one patient in particular who calls and says, or she'll text me and say, "Where are you?" And I'll say, you know, I'm at work. And she said, "So I can call you when I need you?" And I say, "Yes." And she said, "That's all I need." Mm-hmm. So just that availability and knowing is really a large part of what we do. That anecdotal knowing, because you have the experience of it over and over and over again. That's not in the literature per se, but we know what that does. It's like saying that, you know, breastfeeding isn't healthy. We need to study that. It's just like we know that because it's part of the art of what we do. And I really appreciate you saying it's not all about the evidence, because a lot of things aren't studied. But there's a lot of things that we know that are best practices, and a lot of things that really kind of wake our patients up to being known and to being valued. And I think the value of some of our clients or patients who are in shame cycles and stigmatizing positions and judged lifestyles, that, you know, gives them validity and hope. And that's really what we give, right? So I thank you for bringing that to light.
Thank you.
Doctor. Yeah, Dr. Berta. And just so you know, Dr. Ferri, a couple of other colleagues who are listening in the question answer section. One, sadly, and I share their distress, but they're quite shocked at how criminals, particularly drug trafficking, using the COVID-19 pandemic to take advantage, obviously, of individuals with substance use issues. And I think that, you know, obviously you've highlighted that that is an issue. Unfortunately, I think certain sectors of our society will always take advantage, you know, good or bad. And another was saying, particularly about the telehealth, that they gave out tablets and helped with Wi-Fi for many methadone patients and mental health patients who could not afford it. Their counselors, case managers, and some of the doctors were working from home, but largely the group that were at work and staying the course, so to speak, were the nurses who actually went into the practice areas. So that's kind of interesting in terms of which professionals were able to manage telehealth maybe from a distance, whereas nurses, of course, generally tend to have to be in the front line and are known very much as the frontline workers. So don't know whether you'd wish to answer either of those points about the drug trafficking, particularly in COVID-19, from the disruption to the market and the drug sector, and then the use of actually giving out Wi-Fi and Wi-Fi access and tablets to patients. These are both, I think maybe both are in the States that are responding to this.
Unfortunately, I'm not entitled to reply on the security side because it's, as I said, it's not my area of study. If there is a follow-up question, I'm more than happy to put the colleague in contact with my colleague more experienced in that. But yes, in the report I mentioned before, yes, there is this mention of the resilience of the organized crime, the capacity of making profit of any situation, including surely COVID-19. About the question, the discussion we had, we don't have data yet, but there is forthcoming project with the ISAM, exactly, and our colleague Alex Baldacchino, to study better telehealth in Europe, exactly to see how this potentiality, some countries have already developed this before the emergency, how they entered into this spontaneously because of the emergency. We need to assess how much this is feasible, how well it serves the clients, and what can be done to avoid excluding the excluded already. So those that have no telephone, or that are not able to keep a telephone number because they have no money to pay. So I think it's very, very interesting to know, to gather all the information we have and then to discuss and to see. Probably also we can give the idea of this project that is forthcoming is to see what are the experiences around Europe, to try to categorize, and then to share this information. So if there are I know practices where even for the healthcare it's difficult to have a computer. Either they use their own computers or they don't have in the office. And the national health system cannot provide, or can provide only very old computers that do not work with Zoom or whatever. So, and also I can think of a lot of privacy related problems. We need to make sure that these computers cannot be monitored, or that the data or the communications don't go to the wrong hands. So I see there is a lot of work to do. I don't know if it was the answer. It's not an answer.
No, I think, but I think it's a general, the points that you're raising, I think from what I'm seeing from the responses and what people are raising are very global and universal. So, so it's not just in Europe. I think the US is obviously, challenged, and actual fact, the person who posed this has just come back and said, great answer. So I think they feel that you have addressed it. Thank you, John.
Well, Dr. Berta has published the results of a couple of small studies where patients with dual diagnoses, psychiatric and substance use disorders, homeless were provided telephones, and they did not lose their phones. They appreciated being able to communicate with their families, and they had improved outcomes because they were doing medication management over the phone. So it's your study, Dr. Berta, but I wanted to make sure it was brought up. So
that's very interesting. I will connect with Dr. Berta to have this study, because we want also to do a kind of a systematic review of the available literature. This is a very first step study into it, but I think we need to study more to give different options of implementability to the countries that are interesting to go through this way.
I wanted to bring up to you that in the United States, most healthcare is fee for service. And so everything that is provided to a patient is like ka-ching, a charge card. And in US hospitals, physicians and respiratory therapists and other providers bill for their services, but the work of nurses in hospitals is included in the overall bed night fee. And so it's like the woodwork, the air conditioning, and the nurses, And so as long as nurses' services are not reimbursed in the fee-for-service setting with billing, then it's extraordinarily difficult to use financial billing data to quantify what it is that nurses do and to articulate what nurses do and how their work contributes to patient outcomes. So that's a big limitation in nursing research in our country.
This is very interesting to hear. Yeah.
And we also had higher rates of patients going into alcohol withdrawal during COVID because the alcohol stores were closed and bars were closed, and patients with alcohol dependence were not able to get their alcohol supply to keep from going into withdrawal. And patients on methadone were given 2 weeks or a month worth of take-home doses of methadone, which contributed to increased diversion and overdoses. So I want you to get back to your presentation, but I wanted to throw them out there.
This is very important. We really need more studies. This data that I present, not data, these facts that I presented to you were really our first gather of what has happened, but we need to, there will be other waves of this methodology, and we need to have more data. So it's very important to have this exchange from you, because we need to check what is actually happened here. I go ahead and I will introduce some of the resources we developed up to now. One is the so-called best practice portal. It has started already some times ago, passing through different stages, and hopefully soon will become more digital, more accessible. What you can find there is a synthesis of evidence. We have been collaborating with the Cochrane Drugs and Alcohol Group, so with my former colleagues. So there are what we call nuggets, really synthesis of available evidence for area of intervention, substance of use, and target groups. And then this scoring of evidence, you probably know very well, that is beneficial, likely to be beneficial, something that was elaborated by the Cochrane childbirth group, that was the first Cochrane group, and then adopted by the British Medical Journal. So other elements that are in this portal are the implementation tools. Our idea was to create an easy way to implement evidence-based interventions, so that in a kind of competition should have been easier to implement evidence than inventing interventions. One of our implementation tools, the most recent, is called Exchange. It's a prevention registry where we collect evidence-based programs, and then we ask implementers for their experiences. You can search this database by the name of the program, the age of the target group, the setting, outcomes targeted, and some risk factors. And then there is the possibility, is not yet, the interface is not yet really user-friendly, but it will improve. But there is the possibility of consulting the experiences of the implementers, meaning imagine an evidence-based programs like, I don't know, good behavior game. And then this has been implemented in several European countries, and there are short interviews to implementers talking about the barriers they had to overcome, the tips for implementation, the risks. So the idea is to foster discussion in a way that who is interested in implementing this program has really, like TripAdvisor. Can you imagine something that you want to implement something and you read the experiences of those that are already be there? These are the experiences of implementation. And it's something that I like, although can be perfectionate, because I think there is this graal we are searching for, is this expertise of implementers, is this intangible ways of, for example, making an intervention accepted by a community or by a school or by young people. And this is the typical world where nurses are more active. Imagine prevention interventions in the schools, for example, is a typical good example. Here there is a quarterly newsletter. We make a big effort to be able to update our synthesis of evidence every 3 months in order to be able to capture and also to pass to our readers the idea that evidence is not something that is static, it's something that is in continuous evolution. I'd like to, I don't know if I will be able to copy this address in the chat so that you can register yourself to receive these. Let's see if I'm able to do 2 things at the same time. Type an answer here. Okay, maybe Sean can help if it doesn't go in the right direction. Now I want this to disappear. Okay. I would like you to register, not because you need my evidence at all, but just because you can send suggestions for improvement to make this really helpful for people working in the field. So this is what the practice model we created. Is something that has started in prevention, but this is developing to other areas. For example, we are now working on hepatitis C, and then we are working on prisons. So we gather the evidence in a continuous process. We try to also link, identify, categorize, and link to experiences so that someone that is interested in an intervention can also address those that have already implemented these interventions. We try to make the tools available, like any type of guidelines available or manuals for the implementation of interventions. But then, most importantly, we create networks of excellence so that our work is controlled and endorsed by networks of excellence. This is the case, for example, for prevention. We have a liaison with European Prevention Society. They meet every 6 months, I think, to control the contents of our exchange registry. And then we are doing something similar with harm reduction. We are going to create this liaison with ISAM. So this is an open invitation for your organization also to become our stakeholders in the maintenance and improvement of the contents of what we say to support practice. Talking about quality standards. There has been a lot of interest on quality standards recently. I took care of one chapter of this textbook that has been launched a few days ago. The editors are from ISAM, including the elected president, Alexander Baldacchino. And the chapter I took care of tried to describe what are the main tools for implementation, among which recommendations, evidence-based guidelines and recommendations, and quality standards, trying to see how to diversify these two tools that sometimes are confounded, are confused together. So while recommendations, guidelines needs continuous update because evidence is in continuous evolution, quality standards, at least in the interpretation that was made by Europe, by UNODC, by WHO, are more aspirational statements to frame objectives, resources, and outcomes. Just to clarify with an example. There are some European quality standards for drug demand reduction. These are really statements mainly to highlight the importance of, for example, ethicity of interventions, of protection of privacy. This can be operationalized and interpreted at national level in a way that, first of all, they do not enter into conflict with other possible guidelines. Secondly, give an opportunity to keep pace with their own preparedness for improvement. One example I was making at the time was, imagine you want to reduce your waiting list for entering into treatment. Imagine that there is a country where waiting list does not go over 15 days. Their improvement will be to point at 1 week. But if you have a country that has 3 years waiting list, their dramatic improvement will be to pass to 2 years. So both of the countries are looking towards the same direction, but they are doing at their own pace with their own capacity. So we think that quality standards can have this big function of supporting improvement also at different levels. They have been approved by the health ministries of the European countries. They are not binding, but they ensure we are all looking towards the same direction. Just to give a few flavors of what is in, there is the centrality of ethical issues, so consensus of treatment, taking into consideration preparedness to change, being able to tailor interventions to the situation of individuals, the accessibility of interventions for all in needs, patient-centered interventions, training of professionals, access to evidence-based interventions, examples, and individualized interventions, including management of relapse. This is part of treatment. This shouldn't be considered as infringement or guilt or put blame on patients that have a relapse to use. Other opportunities for training I took care is the summer school. We have every year 2 weeks summer school in Lisbon. In this summer school, we actually discuss all the aspects the European Monitoring Center for Drugs and Drug Addiction cover, including security, health, drugs policy, interventions, monitoring. And this is a picture of a group of us coming out of a harm reduction center here in Lisbon. We have plenty of study visits, so people participating can meet outreach worker working in methadone unit, nurses working in treatment facilities. So it's in general is a nice experience for the participants and also for the organizers. This year we had an experience. I'll try to open the door while going on speaking. I'm sorry for this. I'm teleworking, so there are also this type of interactions. This year we were obliged to do an online version, and it was very successful. we realized that we were attracting a different type of participants. Those participants that for personal or working reasons couldn't stay 2 weeks out of their work and spend 8 hours per day at the summer school. So we had a reduced version. We had a reduced version of our summer school, 1.5 hours lunchtime, and we decided to repeat this experience. So we will keep the two versions. There will be a spring version, an online version in spring, in March, the first 2 weeks of March. And then hopefully, if this situation will be over, we will have a presential, a face-to-face edition in June, end of June, beginning of July. Let's see. I will keep in contact if anybody will be interested to this. These were our first experiences with webinars. We started in March, and they were very good. We had a good participation. We use webinars to have conversations on topics we are less, how do you say, we have less consolidated data. So there were really conversations with the experts, and they generated a lot of ideas, and we are ready to start up again in November this year. This is a platform that has been developed in the realm of a European project on prevention. And so we will use this online platform to develop some training ourselves in collaboration with this European project. We have the ambition of becoming more active on delivering of online training. And this is another opportunity for collaboration with you. And let's see, this is still an ongoing project. Sorry. This is still an ongoing project, but we hope we will be lucky and it will be going well. What is boiling, what is still to come, but we are working on it and we are quite keen on having this developed, is a kind of curriculum on treatment in collaboration with ISM, possibly based on existing materials that can be adapted to better serve our audience. This is really something that has not yet initiated even, but I'm keen on disclosing to you because I hope we will have an opportunity for partnership with you all on this ambition we have. I would like to ask if there are any other comments before I go towards a conclusion, and possibly if there is still space, some conversation with you all.
I'm sure certainly we'll just give it a few moments for people to put some questions or comments in the Q&A section, but certainly I'm very excited to hear the boiling with ISAM, because I know, speaking with Dr. Baldacchino, we are also hoping to make a very strong partnership between INSA and ISAM. And also we are opening up the discussions now with ISSUP, who I'm sure you also are very familiar with. So I think that there is certainly a beautiful beginning of a relationship with the European Drug Monitoring Center, but also with these other partners, for us to really think now about the training, certification, on the global level. How can we bring a lot of the silo working that has been happening very nicely, but very much in a very silo, you know, with nurses doing their thing, doctors doing their. We need to come together now to think about what is the general, I think, level that we all need to understand and know in curriculum and in education, and then also what is the specialism, of course, with addiction, and obviously in the US we have great expertise with CARN and CARN AP, so I'm sure that can lend itself very much to the discussion. With ISAP, they are also, as you know, they have ICAP, which is the International Certification for Addiction Professionals. So, and with ISAP, obviously with psychiatrists and with doctors, we have some certifications that is emerging. So I think this is an amazing opportunity that maybe has come about because we are all connecting more virtually. We're starting to hear from each other a little bit more easily, or certainly I think we are connecting more regularly. I'm just seeing if there are some questions. We're having agreed, people are very excited by that idea. And then somebody has asked a very specific question, which is it possible to obtain a copy of the new ESP model? The evidence, I think this is the ESP model that you mentioned. Maybe that needs a little bit of clarification, perhaps, do you think? So for our colleague who is asking that question, evidence-based, the EBP model, the evidence-based model. So
the one that is in my slides before, I can
so maybe they will respond now. The one that was in, yes, so we can maybe scroll back.
Maybe the Hopkins one that you presented.
It might have been the Hopkins one. So we'll just see if our colleague
this one.
I think that
I can share my slides.
Yeah, perfect.
But
that's
just
really helpful.
Really very briefly mentioning the model, consider that nurses.
No, it's your model. It's your model they're looking for.
Ah, okay.
Yeah.
Yes. Okay. Go ahead. It's I call it a model. Probably it's a too big word. It's just something that we are observing works. Here we are. So the idea is that we collect the available evidence and we disseminate it. We try to gather information on the experiences of this evidence. It's what people that is actually implementing this type of evidence. Examples are, for example, testing for hepatitis C, different models of testing for hepatitis C. So we try to gather information. We try to collect all the possible manuals, guidelines, and any type of tools that can help people to implement. But more importantly, we create networks of excellent professionals that endorse what we say, that make sure we are not misguiding people. So this is a model that we realize it works well. We have some experiences and we want to keep it. So this is why I was saying this is an open invitation, because if we will imagine that we will identify some specific nurses' activities, we will gather the evidence, we will gather the experiences, and then any possible tools, but then we need a group of professionals saying, okay, yes, this is still updated. No, this is not any longer good. There have been negative experiences, so it's better you also report negative experience, all this type of activities. Wonderful. We have a big responsibility, I would say, because we decided to disseminate evidence and we don't give recommendations, but we encourage people to implement practices. We need to make sure that it works. We need to make sure that we appropriately report. Imagine if a country without a lot of resources decide to invest on something we are proposing. We are responsible for what they do. So we need to make sure professionals, top level professionals confirms that yes, there is a good opportunity that this will work or not. Make sure you have these conditions, otherwise it won't work.
Perfect. Very nice. Very nice.
Thank you. And here we are. So I don't know why I'm now editing my, okay. We are going towards the conclusions and, sorry. So the conclusions are really support each other in making sure we give a good observation of what is happening. I'm deeply convinced, as you were saying before, Dr. Clancy, you were saying, is it because we are more connected? To some extent, I think yes. Working from home has reduced some barriers, making easier some type of connection. Also, probably restrictions in traveling has freed some of our time. Some of us were continuously flying around the world. Now we are doing this less. People confined at home has developed a bigger appetite for training or for connecting or for webinars. So I think with this big problem and tragedy, because there have been an enormous death toll, there are also some opportunities. And I think we are here to make the best use of this opportunity. Think of your conference. You couldn't have, I do not know, you look very powerful, but probably you couldn't have had a 1 month conference, face-to-face conference. So I think
Correct.
we are here together to try to make the best out of this situation.
Wonderful. Thank you. Thank you very much, Dr. Ferri. I think you are absolutely right. We certainly, we feel we're very powerful, but certainly I don't think we would have been able to do a month conference, not least because of the expense to bring all of the nurses to one area face to face. Usually our conference is from a Wednesday through to a Saturday. So you can see that this is a big departure for us. But usually we are also very delighted if we have about 200, maybe over slightly 200 participants in a face-to-face conference. Whereas on this conference, we are now, I think, almost close to 800 people registered.
Amazing.
Now, understandably not 800 people will actively engage. Over 800 actually, somebody's just updated me, over 800 registered. So even though not everybody may engage actively, some people are students, maybe they are lurking, they're just coming out of interest, but the fact that they will have exposure to over 80 educational events, including webinars of this quality, where we are talking through some of the absolutely current challenges and issues happening in the addictions field is amazing and very exciting. And certainly I'm going to throw it open. We have about 5 minutes, 6 minutes before we finish. It's been wonderful being able to engage with you as we go through the webinar. So maybe we have addressed many of the questions or the comments, but I think maybe one or two people might want to just raise some particular mop-up questions for the session, given we have your time, which we're delighted to have. But I certainly, and I'm sure that the IntNSA organization and the IntNSA board will be more than happy to follow up with you actively on many of the suggestions and the networking opportunities that you've raised in this webinar. So we have somebody coming through. So yeah, so we're just, obviously people are very happy to hear that it's 800 plus, which is true. We're very pleased. That's a very good number, and good point. Thank you, colleague. Are there any other questions for Dr. Ferri before we formally thank her for joining us this afternoon, obviously in Europe, and this morning or just early afternoon for people in the US? We'll just give a few moments. And maybe Dr. Karan Berda and Dr. Catherine Fanini, maybe you would like to come back in. And if you have any comments or thoughts.
I would like to say that this has been my pleasure, and it's reassuring and also stimulating. I'm so honored that you invited us in, and I think I look forward to the collaboration. I think it's the only way we can really make things happen, because global pandemics, be it addiction or COVID, require international work. And so I'm really excited. Thank you so much.
Thank you. And I would like to, I'm not sure, Dr. Ferri, whether you are aware, I'm sure you are, but we have our organization has a journal called the Journal of Addiction Nursing, which is in effect our main organ for evidence-based practice. We have Dr. Ann Mitchell is our editor. And I'm sure we would want to make some connections with her to you, particularly around, sort of the reviews that you've been speaking, and making sure that many of the evidence that is published within our journal is getting over to you as well, so we can incorporate that. I think there's a lovely opportunity maybe also for the journal to connect in with these networks.
Definitely.
And because we have over 80 educational offerings in this conference, and it's pretty much the only positive thing that has come out of COVID, everything is either offered live, like your presentation, and then recorded for asynchronous viewing, or the breakout sessions have all been pre-recorded for asynchronous viewing, and the posters as well. So we would encourage you and all the other listeners today, it's not too late to sign up for this conference. Everything that happened in week 1 is still available to you, and we have 3 more weeks of excellent offerings. And when we were talking about nurses and evidence-based practice, this is how nurses stay current with evidence. So happy to hear about your work with the Cochrane collaboration, because we all teach that in our evidence-based practice courses. And so please share it widely, and understand that you don't have to be a nurse to appreciate some of the research that's being presented at our Addictions Nursing Research Conference. So thank you so much for coming today and sharing with us. It's been a great presentation, and we thank you and all of the people who attended today. So.
Thank you. Kathy or Dr. Fanili. And it's a good trailer just to say that all the new concurrent sessions will be opening just 1 minute past 12 midnight Californian time, and then they open live to everybody, and we'll have the second week concurrent sessions. And of course we have some live events this coming week, I believe on Wednesday. Just for those who are listening, there is 101 in terms of publishing, and our lovely journal colleagues are delivering on that. There's also a live journal club on Wednesday, and of course there will be our journal editorial board meeting, and then next weekend we have another group of webinars, so please do keep an eye on that brochure. Please encourage yourselves, your colleagues and your students to attend, and we'll see you online. Thank you so much, Dr. Ferri. We really appreciate it, and we're going to be certainly staying in touch with you. Thank you, everybody. Have a great day, and we'll see you soon. Thank you. Take care. Bye-bye.
Thank you.